Welcome back to MedNexus. Today, we are tackling chronic kidney disease, and we're going to uncover the mechanics behind one of the most important yet stealthiest chronic diseases in the world. Think about this for a second. What if your kidneys slowly stopped working, but you didn't have a single symptom for years? There's no pain, no warning signs at all. It's a terrifying reality, right? But silently, right under the surface, toxins begin accumulating in the body, blood pressure rises, bones weaken, severe anemia develops, and eventually life-threatening complications appear. This is chronic kidney disease, or CKD, and in this explainer, we are going to understand exactly how this silent killer operates.
Here is our roadmap for today's explainer. We're going to cover normal function, define CKD, look at the primary culprits, walk through the 5 stages, discuss complications and treatments, and wrap up with some high-yield exam pearls.
All right, Section 1, normal function, the body's filter. Before we can talk about failure, we really have to respect the baseline. You've got around 1 million functional filtering units, called nephrons, in each kidney. That is a massive scale. The glomeruli inside these nephrons act as your microscopic filters, while the renal tubules modify that filtrate to actually form urine. But they don't just filter blood and remove toxins. They're total multitaskers. They balance your electrolytes, regulate your acid-base status, control blood pressure, pump out the erythropoietin needed for your red blood cells, and even activate vitamin D.
Moving on to Section 2, defining CKD, the silent destruction.
So what exactly happens when those millions of microscopic filters start taking damage? Clinically, we define CKD as either physical kidney damage or a reduced estimated glomerular filtration rate, that's your eGFR, of less than 60. And here's the kicker. This decline has to last for 3 or more months. The absolute key word to remember here is irreversible. Once this long-term decline locks in, our entire game plan shifts from curing the patient to just preventing that slide into end-stage renal disease.
Next up, Section 3, the culprits. Why kidneys fail. Let's look at the prime suspects here. The 2 most common causes of CKD worldwide actually take completely different paths to destroy the kidney. First up, diabetes mellitus. Persistent hyperglycemia literally wreaks havoc on those tiny glomerular capillaries, leading straight to glomerulosclerosis and a progressive loss of nephrons. Then, you have hypertension. Long-standing high blood pressure batters the renal blood vessels, reducing blood flow and causing nephrosclerosis. Sure, there are other causes out there like autoimmune issues or polycystic kidney disease, but diabetes and hypertension are the absolute heavy hitters we have to watch out for.
Let's break down exactly how this damage actually unfolds. It all starts with that initial nephron damage. But, the kidney is incredibly resilient, so the remaining healthy nephrons step up. They compensate by working overtime, a process called hyperfiltration. Sounds great, right? Well, actually, it's a trap. This creates immense intraglomerular pressure. That extra mechanical stress eventually causes those surviving nephrons to burn out and fail too, directly leading to severe fibrosis and a progressive drop in GFR. It's this vicious, tragic cycle where the kidney literally destroys itself trying to keep up.
That brings us to Section 4, the 5 stages, tracking the damage.
To track this progressive decline, we rely heavily on that eGFR. And looking at the 5 stages, you can immediately see why we call this the silent killer. In stages 1 and 2, where GFR is 60 or above, patients are almost always completely asymptomatic. The destruction is happening, but they feel totally fine. It isn't until stage 3, when that GFR dips below 60, that clinical symptoms finally start popping up. By stage 4, function is severely tanked, and we have to start prepping for dialysis. And stage 5, that's an eGFR under 15. End-stage renal disease. At this point, dialysis or a transplant is absolutely required just to survive.
Let's pivot to Section 5, complications and treatment, fighting back.
Once a patient hits those later stages, we are managing a massive list of systemic complications. Remember, the kidneys regulate almost everything, so the fallout is intense. Patients get hit with severe fatigue and weight loss. Because fluids aren't filtering, they get volume overload. Think pedal edema, pulmonary edema, and worsening hypertension. As uremic toxins build up in the blood, they'll complain of nausea, a metallic taste in their mouth, and even confusion. And since they aren't producing erythropoietin anymore, severe anemia. Add to that painful renal osteodystrophy from wonky bone metabolism and terrifying electrolyte disturbances like hyperkalemia, which can trigger literally fatal cardiac arrhythmias.
Because those complications are so severe, catching CKD early is an absolute must. We're talking a multi-pronged diagnostic approach: serum creatinine and urea blood tests, running the eGFR, and getting ultrasound imaging. But here is a massive takeaway for you: the urine examination. Spotting microalbuminuria is your golden early warning sign. Finding that early, especially in diabetic patients, is exactly how you intervene before the irreversible fibrosis sets in.
So how do we fight back? Medical management here is a full-scale counterattack to slow down the clock. First, we aggressively control the underlying blood pressure, specifically targeting it with ACE inhibitors or ARBs, since they actively reduce proteinuria. Then comes the dietary shift: strict restrictions on salt, potassium, phosphate, and protein. From there, it's about treating the specific complications, replacing erythropoietin to fix the anemia, using phosphate binders and vitamin D for the bone disease, and throwing in oral bicarbonate to tackle the metabolic acidosis. But sometimes, despite everything, the kidneys fail completely. When we hit stage 5, renal replacement therapy is our only play. We generally look at two main dialysis methods. Hemodialysis pulls the blood out, filters it through an external machine, and puts it back. This usually means multiple, long clinic visits every single week. Peritoneal dialysis, on the other hand, is pretty clever. It uses the lining of the patient's own abdomen as a natural semi-permeable membrane, and they can often manage this at home. Of course, the ultimate gold standard is a kidney transplant, but we all know that comes with the harsh reality of severe donor shortages and lifelong immunosuppression.
All right, let's bring it home with Section 6, High-Yield Exam Pearls. Rapid review.
For all you MedNexus viewers getting ready for exams or clinical rotations, you have to anchor this simple AEIOU mnemonic into your brain. These are your absolute indications for when dialysis becomes non-negotiable. A is for severe, intractable acidosis. E is for dangerous electrolyte imbalances, like massive hyperkalemia. I is for intoxication from dialyzable drugs. O is for severe volume overload that's not responding to diuretics. And U is for symptomatic uremia.
Take a mental screenshot right now. Let's do a rapid-fire review of the absolute highest yield facts. The most common cause of CKD? Diabetes mellitus. Your best early marker? Microalbuminuria. The absolute preferred antihypertensives to use? ACE inhibitors or ARBs. The primary cause of their anemia? Decreased erythropoietin production. And the best definitive treatment for end-stage renal disease? Kidney transplantation. Nail these down and you are golden.
To wrap up this explainer, I want to leave you with a thought. We've seen how recognizing CKD early can literally save lives by stopping the silent destruction of the body's filters. But the renal system is a massive, incredibly complex puzzle. So as we continue diving into these topics, which piece of the puzzle should we tackle next? Should we go deep into the mechanics of dialysis, unravel the mysteries of nephrotic syndrome, or break down the tricky balance of acid-base disorders? Let that simmer, keep studying, and I'll see you in the next explainer.